Hello, everyone. Good morning, good afternoon, wherever you are. My name is Deontay Marquis. I am a family nurse practitioner. Been a nurse for 8 years, and I am presenting to you today wound care prevention and management. Now, this presentation about wound care is specifically for the CNA or non-licensed assistive personnel. So if that's you, then this presentation is specifically for you. If you're a registered nurse, please make sure that you're viewing the specific wound care prevention and management registered nurse presentation that I as well present. Both are presented on behalf of my ALF Training. So let's jump right in. Okay, so our course objectives for today, we have a few, but we're going to make sure we check off each one today to make sure you guys leave here with a complete understanding of wound care and the management and all that it requires. So, our first objective is going to be identifying the role of the CNA. What are my responsibilities? What is expected of me? I want to make sure that I do my job well. So, I need to know, Deontay, please tell me what is my role in wound care and management? Next, we need to be able to identify the major pressure points or the areas of the body which are most likely susceptible to pressure sores or pressure ulcers. We need to know where to look. We need to know where to direct our attention to help fulfill our role in reducing wounds in our patients and also taking care and healing those patients who already unfortunately have wounds. Our third objective for today is going to be identifying the different types of wounds. As you may already know, there are 4 stages of wounds. So we're going to talk more about those different stages and also specific assessment findings that you as a CNA can look for and also can report to your nurse that will alert you that there's been a change, something's going on, and I need to report this to the nurse. So we're going to talk about what those specific things we should be looking for when we see our patient, when we assess our patient. Fourth objective for today will be discussing ways to identify and demonstrate ways that we can offload that pressure and different techniques that we use or we can implement in our care to make sure that our patients don't get these ulcers, to help, like I said, play our role in decreasing these pressure sores that our patient may have and that we're trying to help them heal, or we're just trying to prevent because it's a patient who we have identified that is someone who is prone to uh, these pressure sores. And last, our objective for today will be to verbalize. So I want you to be able to verbalize to yourself uh, your understanding of the importance that nutrition and hydration plays in wound care. In my practice as a registered nurse, nutrition and hydration play a huge role in wound care. And it's so unfortunate that those two things are sometimes forgotten about or pushed to the side because and rightfully so, we get very caught up in the actual caring of the wound and the daily rigor, the assessments, the turning, that we forget or we sometimes run out of time to make sure that the patient is hydrating well and has a strong nutritional intake to support those cells which are trying to regenerate and recreate and heal this wound. So we're going to talk about that. I want to make sure that uh, you understand the importance of those two things in wound care. So what I have included here, this is an excerpt from the Journal of Advances in Wound Care, and I'm going to read it out loud. You can read it with me. It says, pressure ulcer formation is very common among patients with conditions leading to immobility, decreased or lack of sensation, as well as malnutrition. So what that's saying is pressure ulcers are very common in these patients who aren't moving around, who for whatever reason have a decrease in lack of sensation. So maybe they had a stroke and a certain side of their body is numb, um, or those patients who are just malnutrition. So maybe a patient is recovering from some form of cancer in the mouth and they don't have a very strong appetite. So they've become malnutrition and they're not moving around as much because they're weak. So they've developed this ulcer. And that's what this paragraph is saying, that these patients are at an increased risk for pressure ulcers, as we can understand. Let's keep reading. Other risk factors include being immobilized on bed for prolonged periods of time, as well as poorly fitted medical devices in contact with the patient's tissues. So these are some additional risk factors that this journal was talking about, in addition to the patient's decreased lack of sensation, the immobility. We also want to identify, the journal article also identifies patients who have been in bed for a prolonged period of time, or those whose medical devices are fitted poorly, and as a result, are coming into contact with the patient's tissues and putting them at risk for developing a pressure ulcer. So I just want you guys to remember these are the type of patients who should be on our radar at all times, as they're going to be the ones who most likely develop pressure ulcer, as this article is saying. Let's keep reading. Risk increases among patients with diabetes, malnutrition, and smoking also increase the overall risk for pressure ulcers. The spinal cord injury population is at the highest risk of developing a pressure ulcer. Okay, so if you are caring for a patient who you got report on that had some kind of spinal cord injury, whether it be from a disease that they had at birth, such as spina bifida, um, or maybe from a car accident or a motorcycle accident or a gunshot victim, if they have some type of injury involving their spinal cord, you need to put them on high alert in your mind, because they are the highest likely of patients that will develop a pressure ulcer. And as we get into this presentation, you'll understand why they're at such a high risk. Next, nursing home patients have a pressure ulcer prevalence of 11% and are most likely to develop pressure ulcers over the sacrum or the heels. So this is specifically applying to you if you're caring for patients in a nursing home. Uh, the patients most likely uh, to develop a pressure ulcer over the sacrum or the heels. So percent-wise, it is most likely your patient will develop a pressure ulcer in the sacrum or on the heel. So we want to make sure we commit this to memory as well, because when we're doing our assessments, if you don't have a lot of time, if you're very busy, or something comes up in the middle of your assessment and you have a patient who has some type of spinal cord injury, but you need to check the wounds for whatever reason before you come back to them to do a full assessment later in your shift, you really want to make sure you look at the sacrum and the heels. And you want to make sure that that's where you're putting the last pillow that you have to provide some extra support to a specific body part to prevent the ulcer. It's the sacrum. So the sacrum is right at the edge of the spinal cord, the spine, right above the buttocks is the sacrum, and the heels, of course, the back of either foot. So that was just an article. I wanted you guys to read that with me so we can get an understanding of how one important wound care is to healthcare, and also so we can see the impact that it's having and identify patients and the areas that are most likely to develop some type of pressure ulcer. And here I included a bit more so we can understand the impact of wound care on the healthcare. Pressure ulcers are one of the most common health conditions in the United States. The AHRQ, that stands for Agency for Healthcare Research and Quality. It's a company that, organization that researches different aspects of healthcare to make sure that quality is improving, to track the quality, make suggestions on how to improve it. And they estimated that more than 2.5 million people in the US develop pressure ulcers annually. 2.5 million. And that was in 2014. And as we all know, more and more people are becoming sick. Health disease is running rampant throughout the United States. So we can imagine that that number has definitely increased. How does wound care affect the patient's life? Well, it has a lot of negative impacts. It affects their quality of life overall because they can't move around as much because it hurts, or they can't lay in their favorite position because maybe that's how they got the pressure ulcer in the first place. So we're constantly turning it. So of course, if I can't sleep in my favorite position because I've developed this pressure ulcer, it's going to disrupt how I sleep. And if I'm not sleeping well, I'm not going to be happy. Um, Sometimes in my experience, these patients, they continue to turn to that side that you're trying to get them to lean off of because that's where the wound is, and they don't follow the instructions, or sometimes they have some kind of a mental disability or disease that they just can't follow the instructions as well as we would like. So the wound gets worse and it puts them at risk to develop an infection. That's a huge problem. Is these patients get the wound, it's not just the wound affecting the sleep and the mobility, but the wound gets worse. It opens up and puts them at risk for infection. And of course, that puts a huge financial impact on healthcare. So what are our responsibilities as CNAs and unlicensed assistive personnel? What can we do? How can we play our part in combating wounds in the US, since we're talking about how big of an impact it is? Um, we can monitor for wound changes. That's one of the responsibilities that we have, is to monitor for wound changes. Also, we can use different techniques. Well, what techniques, Deontay? What can I do? What are these techniques? Well, we'll talk about those later in the presentation specifically, but those techniques are offloading pressure. Offloading pressure is just what you may have already done if you're already practicing as a CNA, or you may have done in clinicals if you're a new graduate. And that's where we offload the pressure. We use a pillow or some other type of device, such as a donut, for the patients to sit on and just get them off of the surface, offload the pressure from just their body sitting on top of a surface for prolonged periods of time. Also, turning and positioning. Turning and positioning the patient is very important. And plays a huge role in the CNA's responsibility and has a huge impact on wound care, healing, or development. It can go either way, but turning and positioning is a very large responsibility that the CNA has with regard to wound care in the patient. Also, another CNA responsibility, how you can help, is to apply wound barrier ointments and similar creams to the wound area. So this is something that the CNA can do. But the CNA, of course, we can't, you understand that you cannot perform open wound care. So I put that here in this big square to the right. So we can apply wound barrier ointments and similar creams, but only if the wound is closed. So primarily our stage 1 wounds. And we'll talk more about what a stage 1 wound means. But just know that if the wound is open, when you are cleaning the patient's sheets, performing your assessment, performing incontinent care, if you see the wound and it's open and you want to apply some type of barrier cream to it, stop. Before you do that, you need to let the registered nurse know. You need to let the registered nurse know to make sure it's okay, because sometimes these wounds, the doctor has specific orders, and especially if they're open. We only want to put certain types of products around or even inside an open wound. Because of course, if it's an open wound, it's very susceptible to infection. So if it's a stage 1, which means it's only on the surface, a reddened area, then it's okay for us to apply this wound barrier. But if it's not, If it's open in any way, if the skin is broken, then we need to ask the nurse. And of course, when we're doing basic dressing changes under RN supervision or direction. So if your patient has an incontinent episode and they have a stage 1 wound on the back, and the dressing over that stage 1 wound was indeed soiled during the incontinent episode, it's okay to change the dressing to clean the wound, wipe any area that may have been saturated from the episode, and apply a clean, new, dry dressing, and also some barrier cream. But just make sure that we let the nurse know that we're changing this dressing, and also let the nurse know that you're going to be performing this dressing change and using barrier ointment. Or if you don't have a barrier ointment, ask the nurse, hey, is it okay? Would you like me to? Should I use a barrier ointment? I'm going to change Mr. Johnson's wound dressing on his back. So this is what the CNA can do. These are our legal responsibilities to wound care for our patient. Additionally, we should be helping to maintain patient hydration and encouraging adequate nutrition. We should also be assisting the RN with turning and repositioning high pressure areas, monitoring and alerting the nurse of any changes in the wound. So we just talked about this on our last slide. I just summed up the 3 most important responsibilities here that, in my opinion, the CNA should fulfill if their patient has a wound or their patient is at high risk to develop a wound. Maintaining hydration, encouraging adequate nutrition. This will show in the effort the CNA puts forth, helps the patient drink and properly take in nutrition, encourages eating. This will help the wound heal. This will give the skin its strength to prevent any more wounds from occurring or the current wound from worsening. Assisting the nurse returning and positioning. If you see that the nurse is busy having tied up with other patients, and you know it's time that the patient needs to be turned, go grab the nurse. Hey, come on, let's turn Mr. Johnson. It's 2 hours. I know you're busy, but we got to do this. I'm here to help you, and let me know if you need any other help. And also, when we assessing the patient by ourselves, when we're changing Mr. Johnson's gown or giving him a bath, we need to be monitoring that wound site and alerting the nurse of any changes in the wound. So, where is the wound? Where is the wound? That's the game we're playing today. Where is the wound? The wound can be anywhere you see a red dot here. Why? We're going to talk about it. So, the most common areas are the shoulder blades, the buttocks, we talked about that, and the sacrum, right? We actually talked about the sacrum, which is the lowest point of the back. The buttocks, specifically the soft tissue. So, 1, the buttocks, soft tissue area. 2, the sacrum. And 3, the shoulder blades. And then here you see the buttocks from sitting, the pressure there. That's why the soft tissue area, the sacrum, of course, from lying down, the shoulder blades as well from lying down. These are the areas in patients who are malnutrition, their shoulder blades really protrude, they show through, and they have soft skin. And the shoulder blade is a very bony, prominent area. So it comes in a constant rubbing contact with the bed. So these are prone. But all of these areas, make note of all of these red dot areas. So here we have the hip, the knees, the toes, the heels, right on side the knee, the hip on the side. This is the pelvic on the front, the top of the shoulder. This is the ear. Anywhere down the back. Remember, we talked about our spinal cord patients and how they are the most susceptible to wounds. This is why we can see all the areas on the back, because the spine is such a bony, prominent area that covers a large area of the body. And when we're lying down, most people sleep on their back. So it's very important. Okay, let's move on. So high pressure areas. I'll point them out here: the toes, the heel, the buttock, the elbow, the shoulder, and the head. These are areas of the body that have bony prominences, which commonly come in contact with flat surfaces for prolonged periods of time. That is a high pressure area. So you can decide for yourself when you're looking at your patient where the high pressure areas are. Um, you can see how they sit, how they position themselves in bed, and you can make a safe assumption that if that patient stays in that position for a majority of the day, for the rest of the week, I'll likely see some breakdown on their elbow because Mr. Johnson likes to sleep on his elbow when he falls asleep. So these are the areas that we should be monitoring. These are the areas we should be uh, we should be focusing our attention on to make sure that no pressure ulcers develop and we're doing everything we can to prevent one from developing. Now, there's another type of pressure-related wound that can occur, and they can occur in pressure areas related to medical devices. So, what do you mean, pressure areas related to medical devices? Medical devices are supposed to help patients. They're not supposed to hurt the patient. So what are you talking about, Deontay? Well, I'm talking about areas of the body that have frequently come in contact with medical devices for prolonged periods of time. And they can come into areas of soft tissue or bony area over the body. Remember in the last slide, I'm sorry, 2 slides ago, you can see the buttocks is a soft tissue area. So is under the thigh here. So is this side of the calf. This is soft tissue. But on this slide, I made note of bony prominences. So when we're talking about pressure wounds related to medical devices, they can occur anywhere. Wherever there is a medical device that is coming in frequent contact with the body, whether it's a bony area or a soft tissue area, we may see some pressure related wound in that area. Examples would be a nasal cannula. Why? Well, think about it. When you put the nasal cannula on, it goes under the patient's nose, up the cheeks, and around the ears, and it comes down and ties under the neck, right? Well, this whole area is soft tissue. And if we tie it too tight underneath the patient and it's pulling, and we don't reposition it, we don't move it, we don't take it off, that patient's on continuous 24/7 oxygen. When you take it off at the end of the week, you'll see a very red, strong indentation, and it'll probably be a stage 1, meaning it'll be some notable redness along this area, but specifically behind the ear, because that's where we commonly hook and we're putting the most pull the uh, on the medical device, on the nasal cannula. So make sure if your patient's on nasal cannula, we're checking behind the ears. And if they're on 24/7 oxygen, or they have all of the signs that we talked about, that we read in the article that we've been talking about, of patients who are highly susceptible to wounds, then we want to make sure that we're taking it a step further and we're not just looking behind the ear for a wound, that we're preventing. So we're using some type of cloth, some type of gauze to wrap around the medical device to act as a barrier between the skin and the device from constantly rubbing together and creating that wound. Also, another area of soft tissue that is frequently found to be an area of pressure related medical device, pressure wound, I'm sorry, related to medical device would be the Foley catheter in the inner thigh. So I know it's hard to tell by this picture, but this is the thigh and this is the catheter. And this is where the catheter was sitting for way too long without moving. And you can even still see how it's so tight. So what happened here? Well, the medical staff wasn't repositioning the patient If they were, as they repositioned the patient, this would have moved there. As they turned the patient to one side, it would have moved over here. When they moved the patient to the other side, they should have been bathing the patient properly, assessing for some type of redness, and then using preventative measures to prevent that redness from getting worse. And they didn't do any of that here. As we can see, this is a very prominent reddened area. So this is what a stage one, I would call it a stage one pressure wound would look like. But you can see here how it's deeper reddened. That lets me know that it's going into a deeper area of the tissue through the skin, and it's headed towards a stage two. And we'll talk about the differences between stage one and stage two. But here for this slide, I want you to be able to understand that uh, wounds can be found above where? Bony prominences or soft tissue. And when we're talking about high pressure areas, we know that all of these areas here and these areas here, basically anywhere that the body is in constant contact with the surface is where we can find a pressure wound that can possibly occur. So we want to make sure we're doing a full scan of the patient's body. Okay? All right. So stage one. So if you compare this picture of this reddened area of the sacrum, and remember we talked about the sacrum being the most common site of a wound in patients who are in a nursing home. If you compare the redness there to the redness here, you can see why I said that was a stage one on this previous slide. Okay, so let's read. Skin is not broken, but is red or discolored or may show changes in hardness or temperature compared to surrounding areas. When you press on it, it stays red and does not lighten or turn white. Blanch. So I want you to make mental note of that word blanch. Blanch is when you press on your skin and it turns white, but then your color comes back into that white area. So basically, when you press on your skin, you're pushing any blood away from that area, which is why it turns white, because you push the blood away and then it comes back because the blood comes back into that area. So that's called blanching. So when you press on it, it stays red and does not lighten or turn white. That means that there's some permanent damage there in the skin. Well, not permanent, but there is some damage there. And that lets us know, that's another indicator that this wound is officially a stage one. The skin isn't broken, but it's red. It can also be harder there. Maybe the skin isn't as soft when you rub over it, or maybe the temperature there is warmer, or maybe it's colder. But you should definitely, with the back of your hand or even your fingertips, feel for a temperature difference around the area. Sometimes there won't be a temperature difference, but sometimes there will be. This is why we need to check each wound. We can't assume that one patient's stage one is going to be the same as another patient's stage one, and therefore there's no reason to check it. No, that's not acceptable. We need to check for the temperature. We need to check how it feels. We need to use our hands and our eyes to look at the wound and decide for ourselves what we think, what stage we think this wound is, because we're going to go report our findings to the nurse. And if the nurse let us know that it's a stage one, and we go here and we find that it's a stage one, then we know that the last nurse and CNA have been doing their job, because this wound hasn't gotten any worse. And we're going to do the same. We're going to make sure it doesn't get any worse. We're actually going to go one step further and make sure this wound improves. So that is a stage one. A stage two, as you can see, the skin is broken. So this area here is still reddened, but you can see here it's a brighter red in the inside of the wound, and the skin is broken. So that is why you can see on this slide, I said it looks like it was forming a stage two, but it's hard to tell from this picture. So stage two, let's read. The top layer of the skin is broken and there's a shallow open sore. The second layer of skin may also be broken, but the wound doesn't tunnel through. Drainage, pus, fluid, all of that, it won't be present in stage two. So if you see drainage or pus, And it looks like a stage 2. It probably isn't, because the top layer of the skin is broken, and in order for that pus and drainage to come through, we need to break through another layer of the skin. Now, there may be some, if it's a fresh stage 2, if it just occurred an hour ago, maybe a little bit from where maybe a sore burst of skin that was covering the stage 2. But let's stick to this definition. Let's not talk about what if situations. In a stage 2, the top layer of the skin is broken. Okay, that's how we separate a stage 1 from a stage 2. So this would count as an open sore, and this is not something CNAs should perform wound care on. This is not what we should perform wound care on. We should only perform wound care on a stage 1. And we talked about this because there are different, types of barrier creams. There are different methods that the doctor may or may not want to, or the wound care nurse may or may not want to implement to care for this wound. And even when we're doing a stage 1, we're doing closed wound care because this wound is closed. We want to let the nurse know, and we even maybe want to be under their supervision. So stage 3. Now, you don't need to know specifically stage 3 and stage 4. Why? Because stage 3 and stage 4 are well past the scope of responsibility that for a CNA. This is strictly for the nurse to provide wound care for. But don't be confused by what I'm saying here. Even though you will not be required, or it is not your responsibility to perform wound care on a stage 3 or stage 4, we still provide wound care management to patients with a stage 4, a stage 3, a stage 2, or a stage 1. I just want to make you guys aware of the differences between these wounds. So when you step into a patient's room and you pull back the sheets, you are not mistaken for, you do not mistake a stage 2 for a stage 1 or a stage 3 for a stage 2. So we can monitor the progress or the lack of progress throughout our shift, report it to the nurse, report any abnormal findings. Because if we know that for a stage 2, drainage and pus should be present, and you perform and drainage and pus are present, we know that that stage 2 may have evolved to a stage 3, and we need to just know. So that is why we are talking about these differences, because I want you guys to be able to report everything to your nurse and be amazing caregivers for our patients, for your patients, for our patients. All right, so a stage 3, let's read. The wound extends through the second layer of the skin and into the fatty tissue, but bone, tendon, and muscle aren't visible. So you can see this wound goes a little bit deeper, and this white area here, that is how we know this is kind of fat. And this here, it's reflective. It's hard to see in this picture. That may even be some pus. It definitely looks like along the brim here, but it's very likely that they cleaned this wound before they took this picture. Uh, but this is definitely a stage 3. We've already extended through the reddened area. So we see the reddened area here. And we've broken through the top layer of skin. So see this bright red and see it's bright red. We've broken through that top layer, and this wound is going just a bit deeper. So now it's through the second layer of skin. And last but not least, I hope none of you ever see this in real life, but chances are many of you will, unfortunately, is a stage 4 wound. And this wound extends into the muscle. It extends even as far down to the bone. And there are usually a lot of dead tissue and drainage are present. So we can see here some drainage and fat. I'm not sure what this is, but you can see how deep this wound goes. And this definitely looks like a sacral area of a patient. So stage 4. And just a different view. I wanted you guys to get a side-by-side view, a more anatomy view of what a stage 1, stage 2, stage 3, stage 4 wounds look like. So of course, this is the top layer of the skin. It's red and inflamed, but not broken. Here, it's broken past this top layer of the skin, and it's not as bright red compared to here. It's actually a darker red. And then here we can see, we talked about for stage 3, it extends through the fat. It's broken through this second layer. So first layer, second layer, and right below the second layer is the fat. So it's broken through the first layer, the second layer, and we're into the fat now. And then stage 4, it's broken through the first, the second, the fat, and we're actually getting to the bone. This is the bone here. So this is a side by side by side by side view of wound progression, the 4 stages of a wound. Okay? So we're moving along. Wound assessment and findings. What should I be looking for if I am caring for this patient? Well, if we are caring for this patient, we should be looking for a few things when we're doing our assessment. We should be looking for the location of the wound first. Where is the wound? The wound's on the foot. We should probably look at the other foot as well. Uh, why should we note the foot? Well, because we want to make sure that when this patient's laying down, we float it off the heel. We provide protection to it, that we're taking the sock off of the patient, the shoe off of the patient after we walk. We were questioning, should we even be walking this patient, having them put any pressure on it? So this is why. There's the location of the wound tells us more about how we should care for the wound. So once we figure out the location, okay, it's on the right foot, then we go down to the patient's right foot. We take their sock off. We take any gauze off, or maybe there isn't any gauze on. Maybe it's just a stage 1. So we look at the wound. There's no skin broken. It's just very red. Okay, this is a stage 1. This patient's lucky because CNA, whatever your name is here to save the day. I'm going to erase this wound from your heel with my amazing wound care that Deontay taught me. So the stage of the wound is a stage 1. If the first layer of the skin was broken, it would be a stage 2. And if it's a stage 2, I'm gonna ask you guys a question. Do we have drainage or do we not? If it's a stage 2. It may or may not. So it may or may not be present. So if it's a stage 2, it may or may not be present. Don't forget, guys. So we're looking for drainage. Is there drainage? Okay, there's no drainage. It's definitely a stage 1. I'm not sure what that is, but it's not drainage because the wound isn't open. Is there an odor? If there was an odor, it would probably let us know that there was some dead tissue. And if there's dead tissue, it's probably a stage 4. And again, we're making sure we note the color and redness of the area. So it's a stage 1. Is it blanchable or not? If you press on it, does it stay red or does it turn white? Likely it's just going to stay red because it's been what? It's been injured. There's a pressure injury to the area. So I'll keep talking about the heel, and the pictures I showed you were of the sacrum. Why? Well, if you remember from the first slide, the article I put in the presentation, the most common areas of pressure injury in patients in the nursing home are to the heel and the sacrum. So here, what can we do? Our patient needs wound care or they need wound care prevention. This poor patient has a stage 1 on their heel. Well, we can offload the pressure. This is what they're doing here. It's also called floating the heel. So what it looks like the caregiver has done is put this patient to the edge of the bed, or they may have propped the leg up on a pillow to get the heel and the foot up off of the bed into the air. So now the heel is essentially floating. There's nothing touching this heel except for air, and therefore we're not causing any more pressure to touch this heel. We're allowing it to heal. We're allowing the heel to heal. We're letting the heel heal when we float it in the air like this. What else can we do? We can reposition the patient every 2 hours, making sure that we're turning the patient from side to side. Maybe they don't like having their leg floated. So we're just making sure we're turning them from side to side. So they're not laying on their back. So the foot isn't resting completely on the heel. We're turning them from left to right, maybe putting a pillow in between their ankles. You see, so we're still floating the heel if there's a pillow between the patient's ankles as they're laying on their side. And we're keeping the head of the bed less than 30 degrees except during meals. Now, this specifically is going to help with sacrum and also heel, because when you raise the patient's head of the bed, you're putting them in more of a sitting position. And so the weight is going to be distributed a bit more evenly to the soft tissue of the butt. That's going to provide pressure off of the sacrum. And as long as they're not like sitting on the edge of the bed, or they have like a foot rest at the bottom of the bed that they're sitting in, that they're always putting their feet against because they may be a taller patient, then if we're keeping them less than 30 degrees, we're relieving the amount of pressure to those areas. So what else can I do, Deontay? I want to help my patient. Well, some more small tips that you can take that will help your patient. Uh, Keep the bed free from crumbs. That could irritate the skin. Now, this sounds like common sense, sounds like something very easy, but if you've been in healthcare as long as I have, then you know that this is an uphill battle because your patient is eating in the bed. That's where they eat most of the time. My patients, for some reason, they just didn't like getting up into the chair and sitting with the bedside table to eat. So we let them eat in the bed, and they get crumbs in the bed, and they don't always let you know that there's crumbs in the bed. And so when you're turning them around lunchtime or every 2 hours, you may notice that there's an indentation on their skin. Why is that? Well, it's because there's a bunch of breadcrumbs that are underneath their side that they're laying on, and those can actually irritate the skin over time. So we want to make sure we keep the bed free from crumbs. Maybe lay a towel down when they're eating to catch the crumbs. And then that way you can just toss those crumbs into the trash and keep them from irritating the patient's skin. We also want to avoid dragging the patient over the sheets. Patients with weaker skin, this can actually weaken the skin and cause skin tears. I've seen it happen just simply pulling the patient over the sheet because they didn't have a proper pull sheet under the patient. Instead, we want to make sure we bend their knees. This is going to take just redistributing the weight, having the patient bend their knees and then moving them or turning them. Also, if your facility has offloading boots or elbow pads or extra pillows, you need to request them if your patient fits the description of someone who's at high risk for a pressure ulcer or someone who already has a pressure ulcer. Um, they make a huge difference, and the patient will thank you in the long run for fighting to get that extra pillow in their room to float their heels, or using those offloading boots. And you don't have to wait until the patient has some type of redness. You can ask for these things if you feel like the patient isn't moving as much for whatever reason, or it's been a 3-day span where they're just not wanting to walk, their energy is declining, and for whatever reason, they're just laying in bed in the same position. We can request these items and say, hey, I don't want this patient to get a skin ulcer on the heel because I don't want them to have an infection, because I understand that they're really sick. And if they get any type of infection, it could really put them in a bad space. So I would like to request some offloading boots and some pillows for this patient because he's been laying in the bed for a very long time for the past few days, majority of the day, and I don't want even a stage 1 to start. Some small daily preventative care tips that we can use: elevate any area of the body that may be swollen or any areas of edema. Why? Because that extra fluid in the area causes pressure on the skin, and it almost acts as a accelerant, almost like gas to a fire when it comes to wounds. So we want to make sure that we elevate that area, we get that extra fluid back into circulation. Also, if there isn't a wound to the area, but let's just say it's weakened skin and we notice some weeping. So underneath the leg, let's say a patient has some edema and we see just some strange fluid or some it looks like sweating, but we're not sure. And you can see that there's obvious weeping or the fluid is just coming through the patient's pores. We want to report that to the nurse. One, because that can be a sign that something more serious is going on. And two, because this is something that we need to address because if the patient is weeping in this area, then it is going to, again, act as an accelerant, act as gas to a fire and accelerate the wound, any kind of skin breakdown, which could lead to wound development. And last but not least, protect the heel. We have to heal the heel. It's very important. Protect the heel. They're so common, and the sacrum as well. I should have put protect the sacrum as well. Um, let's see. So, okay, assess and apply compression stockings. So a lot of patients, the doctor orders compression stockings. This is something that the CNA helps out with a lot of the time in my practice. So when you're doing this, when you're checking your patient, um, when you take them for a walk or help put the stockings back on, or you're taking over for your shift, check those compression stockings and make sure they are smoothed out, pulled all the way up, because they're there to compress. So if they're not smoothed out, then there's too much compression on one area. It's stopping the blood flow to the tissue in that small area. And then what can happen is a skin can break down in that area. That skin is just being, in that area is being weakened because it has no blood flow. The tissue isn't perfusing with blood. It's not growing. It's not getting the nutrients it needs. So it's getting weak. And unfortunately, it takes something as small as that can lead to a wound, a pressure injury. And this could be another example of what type of high pressure area related uh, wound. A medical device related high pressure area would be the legs or anywhere the compression stocking would fall. So there are thigh highs and there's knee highs. So there we go. And of course, as always, notify the nurse if you see that the compression stocking wasn't smoothed out and you smooth it back out and you see that the area is white or it's blue where that compression stocking was cuffed at. Or the patient starts to report increased leg pain. This means that they're having pain from not having enough blood flow to the area. So we need to let the nurse know. That's a big thing if they say they're having leg pain and they wear compression stockings and they weren't applied properly. Let's see. So skincare, key points. I'm sure everyone already knows this. I'm beating a dead horse, but key points. Moisturize dry areas of the skin, dry, moist areas of the skin, and powder in between the folds. Those are my key points for skincare for you guys. And that's how we prevent this here. By moisturizing the dry areas, drying the moist areas. If they just had a bath, make sure we dry all the areas and powder in between the folds because that moisture creates a breeding ground for bacteria. That bacteria will break down the skin, weaken the skin, and create a possibility for a skin breakdown. We want to make sure we're following those key tips. What products are you using? Everyone's facility is using a different brand name or a different type of product, but I included these pictures here just to demonstrate this is what I'm used to using. Cavalon Durable Barrier Cream. This is not a promotion for their brand in any way, nor are we supported by the brand anyway. Barrier cream, best used to protect the skin from moisture damage, and we should use this after incontinent episodes. Don't wipe it off. It should be something that's applied generously to the area, so there should be a lot of it, because we can expect if we're applying it to the sacrum, some of it's going to get rubbed off. So we want to make sure that as much of it is in place to prevent as much friction between the skin and the surface as possible. Also, just this slide, I talked about powdering in between the folds. If you don't have powder or your patient doesn't like the powder, then Interdry AG. This is a moisture wicking fabric that we can put in between the folds to make sure we're catching any moisture. Maybe your patient is overweight and they sweat a lot. Using uh, this material can keep the area dry, and it's also infused with an antimicrobial agent. So this is something you should ask your facility for. This is something you should start using on patients who are overweight, who maybe or just sweat a lot or have some folds that are the skin. You can tell it's losing its strength, it's breaking down a bit, and you want to help protect it and make sure that nothing happens. No skin breakdowns, no tears. We can ask for some type of moisture wicking fabric. So, wound care and preventions, what to use and when to use it. This is very important. So, we should be using on a stage one. Let me get my slide back up here. We should be washing the stage one. Remember, that's just a reddened area with warm soap and water. We should use a new wash bin and towel when we do this because we don't want to introduce any new bacteria into the area. And remember, be gentle. We're not scrubbing a stain off of our brand new kitchen table. We're wiping a very reddened, sensitive area of the patient's skin clean just to get any bacteria off of the area. And for stage 2 through stage 4, we talked about wound care should be done by the nurse or only with RN supervision. So it depends on your facility. I know CNAs can obtain a, wound care certification. So that's why I said should be done by the RN or only with the RN supervision. But the takeaway here should be stage 2 to stage 4, we should not be doing anything for it except for prevention and management of. We shouldn't be doing anything in regards to dressing changes or things like that. So, nutrition and hydration. I have this big and bold at the top. Proper nutrition and hydration helps prevent skin breakdown and promote skin healing. Nutrition on the left, a well-balanced diet is very important. And specifically, I want to highlight the foods here that can give our patient a protein dominant diet, unless specified otherwise by the nurse. So we want to make sure if they're not eating a lot, that they eat their red meat. If that's on the plate, they eat their fish or their beans, their cheese and their yogurt, nuts, things like that, that are high in protein because the protein essentially helps heal the body on a cellular level. Hydration. Did you know dehydration can thin the skin and decrease elasticity? So if we decrease the elasticity due to dehydration, then the likelihood of a skin tear is increasing every day. We want to encourage the patient to drink as much water as possible. Recommendations are 8-ounce glasses of water, that's 64 ounces, unless otherwise specified by the doctor or the nurse. And that's it, guys. You've made it to the end. I hope you're still awake over there and I haven't bored you to death. I know I haven't. I know you're paying attention because you love this information, you love your profession, and you want to become a better caregiver. So, review question number 1, just to see how well you were listening. While bathing a patient, you notice a bright red area on the left heel. You press the area and note it does not turn white. When reporting to the nurse, what stage pressure ulcer would you suggest the patient has? We talked about the healing the heel all the time throughout this presentation, so I know you guys got this. I'll give you a second to answer the question. Stage 1, if you pick stage 1, you were right, and you understand the differences between stage 1, stage 2, 3, and 4. Specifically stage 1 and 2, because that is how you guys determine what is okay for you to dive right in and do care for, and what you should stop and say, hey, I think this is stage 2. I should definitely ask the nurse if this is a stage 2, because if so, I know that I'm not allowed to do certain things for this wound. And I want to make sure I do the right thing as delegated by the doctor or the nurse. Question number 2. If you got question 1 number wrong, here's your chance. Which of the following is not considered a high pressure area that should be routinely checked for signs of pressure and redness? So which area is not high pressure? Which area is not high pressure? I showed you guys 3 or 4 different diagrams with high pressure areas on the body. I showed you soft tissue and bony prominences. So I'll give you guys a minute to answer this question. Okay. So none of the above. All of these areas are considered high pressure areas. Remember, we talked about high pressure areas. The most common are patients who have some type of spinal cord or spine injury. We talked about patients who may have been in a car accident or a motorcycle accident. These patients are the most likely, and the most common areas for patients who are in a nursing home are the heels of the foot and the sacrum. And on the diagram, on the front of the hip and the side of the hip were noted as prominent areas, bony areas of the body, which are susceptible to pressure sores. So that concludes our presentation. I'm just going to go through this summary with you guys just to review over what we learned. We went through all of our objectives. Our first objective was to identify the role of the CNA. So we've identified that role. We've talked about what your responsibilities are. What are they? Monitor for wound changes. Alert the nurse if there's any out of the ordinary changes, or you think your wound has progressed, or if when you were given a report, it was considered a stage 1 and now there's drainage and pus, then you know that something has changed. Applying preventative techniques to prevent your patient with a stage 1 wound from developing a stage 2 wound. Applying wound barrier ointments and other creams. I say other creams because we talked about the importance of moisturizing dry areas to prevent skin cracking and tearing. And basic dressing changes under RN supervision direction. We should be getting RN direction and supervision on how to make a basic dressing change to a stage 1. But if there's a stage 2 or past, more than likely, we are not going to be providing dressing change to those areas. But if we are, it's going to be with the assistance and direction or supervision of the nurse. Our second objective was identifying major points of the body. So we identified that bony prominences and even soft tissue in relation to medical device pressure can be areas that are considered major pressure points or high pressure areas. And these are the areas of the body that we should be paying attention to, applying preventative techniques to prevent pressure from developing into a wound or ulcer on the body. Our third objective was to identify various wound types and important assessment findings. So we talked about stage 1 and stage 2. We also talked about stage 3 and stage 4, but specifically stage 1 and 2. And we talked about specific things to look for, and those were the location of the wound, the color or redness of the wound. Is that area blanchable? When I press it with my thumb, does it turn white or does it stay red? We also talked about drainage coming from the wound. And remember, we talked about which stage may or may not have drainage, and that was stage 2. It said may or may not under our description. And also odor. If there's an odor coming from the patient where the wound is, then there's likely some dead tissue. And dead tissue occurs with stage 4. Our fourth objective was identifying or demonstrating pressure offloading techniques and methods. So you guys probably are already doing this, but just to reinforce, we're making sure here that we're not pulling the patient across the sheets because that can accelerate the skin tears or further weaken the skin. We're bending the patient at the knees when they're sitting up to prevent, uh, to relieve, I'm sorry, that pressure. We're also using elbow pads or pillows and floating the affected area. We talked about floating the heel off the side of the bed to prevent uh, pressure, to prevent wounds, but more importantly, to decrease the time that there's friction between a specific part of the body and the surface that's causing this skin breakdown and this wound to develop. And our last objective, objective number 5, was verbalizing and understanding the importance of nutrition and hydration. I told you guys in the beginning of this presentation that wound care relied heavily on the care that we give the wound, but also the nutrition and hydration plays an important role in helping heal the wound and keeping the patient's skin strong. And we talked about the different types of sources of protein. If there's a lot of food left on the patient's plate and they're not very interested in eating, we want them to eat the protein-rich food, and that would be your red meat, fish, Greek yogurt, nuts, cheese, things like that, where they're going to get the protein from, because that plays an important process in nourishing the cells to help heal any wound. And also, we talked about the amount of water they should be drinking, 64 ounces of water. And of course, these type of diets, highly protein rich, or making sure that they're drinking a lot of water, only if it's okay with the nurse as ordered by the doctor. So if the patient has some type of health related or disease related issue where they should not be eating too much protein or they should not be drinking too much water, then we want to tailor the nutrition and hydration needs of that patient to the doctor's orders or the nurse's instruction. And that's it. You guys made it to the end of our CNA and UAP, Unlicensed Assistive Personnel, Wound Care and Management presentation. I want to thank you for sticking with me. I hope you took a lot from this presentation today. And again, my name is Deontay J. Marquis. I'm a family nurse practitioner here in Southern California, and I'm presenting to you on behalf of my ALF Training. And I will see you next time. Have a good day.